So it's my privilege today to introduce two grand round speakers, actually. First one, Dr. Atur, and second one, Dr. Atsushi Okada. So I'll start with Dr. Iturra. Dr. Iturra did his medical and surgical training in Chile and led a cardiothoracic surgery fellowship at Mayo. After his cardiac surgery fellowship, he's done two additional fellowships, one at Emory in transcatheter valves and a second at the University of Pittsburgh in mechanical support and thoracic transplantation. After that, he worked in Chile and subsequently came back to Temple University working in thoracic transplantation. It's been a little under a year now since we recruited Dr. Atura to our practice, and he's been focusing on valve disease, transcatheter and open, as well as heart failure and transplantation. Second, Dr. Atsushi Okada is an interventional cardiologist from Japan. He's been with us for almost 2 years now as a research scholar in the Valve Science Centers. I've been working primarily with Dr. Bapat. So both of these two will be sharing today on the current state of surgical left atrial appendage occlusion. So, Dr. Atur.
Good morning. Hi, everyone. Thank you for allowing me to present today, and thank you, Bobby, for the introduction. So I have no conflict of interest. And just to summarize what we're going to talk today, our objectives is to understand the basis of left atrial appendage occlusion or exclusion, and for stroke risk reduction. We're going to talk a little about the history of left atrial appendage exclusion and different surgical techniques. We're going to talk about trials regards occlusion and the future trials, and we're going to make a conclusion after my presentation. And as Bobby was mentioning, Atsushi Okada will talk about local research study of CT analysis in left atrial appendage occlusion. So to start this, as an introduction, atrial fibrillation is an important risk factor for stroke. And we know that 25 of the ischemic strokes are attributed to atrial fibrillation, and this carries a significant amount of disability and death. Anticoagulation has led to a decrease in this stroke. Around 2/3 are decreased with Coumadin, but we know that anticoagulation comes with an increased risk of bleeding, and also with time, there's a poor adherence even with warfarin or DOAC. There are studies that 30% of 2 years, patients are non-adherent even with DOAC that are more easy to take. Also, as introduction, in atrial fibrillation, the thrombi comes around 90% from the left atrial appendage. It's a little less on patients that have valvular atrial fibrillation, but it's still significant. Regards to surgical technique, it has been described since early times in cardiac surgery, since 1948. And there's a lack of standardization, which is the best technique. There's been different description, and that probably why confusion of the success of on its results. And the results of how to classify successful technique is being a consensus that it should be with the lack of flow and a residual stump of less than 1 centimeter. Now, regards with the techniques, I think we can summarize this as two big difference as an epicardial or as an endocardial approach. The epicardial one is basically outside the heart, and there has a different division. One is the epicardial exclusion, which means sewing the left atrial appendage from outside, and the other one is exclusion through devices. And devices have been a lot of technology through the years. The beginning was a stapler as one of possibilities, Tiger Paw, which is not available anymore commercially, and the clip, which there are two big companies that are able to have it, the Etriclip as one of them, and Medtronic, which has been recently released. Now, the other different epicardial approach is epicardial excision, which means cutting the left atrial appendage and suturing afterwards. Now, with the endocardial approach, which necessarily means going on cardiopulmonary bypass, arresting the heart and open the left atrial to have exposure to the left atrial appendage, is suturing from the inside. And there's a hybrid approach with the lariat device. This is a drawing of our different techniques. The first in the drawing, as said, number 8, is the loop device, which is a suture outside the heart. On the B, that's a stapler, but the principle in the clip is the same one. And C, as you can see, there's no more left atrial appendage. It was cut off and sewn afterwards, which is a surgical approach. And the C is a pursue string. Now, with the endocardial, as we mentioned, it has to be done with cardiopulmonary bypass. This is the heart is arrested, the heart is open, the left atrial appendage is exposed, and you can see inside with the suture around there, you can exclude it too. Now, with all these different techniques, Cleveland Clinic published this many years ago in JACC 2008, which they did an assessment with a transesophageal echocardiogram to make sure how efficient, how successful we were with the left atrial appendage closure. And they concluded on patients that that had excision, there was no residual flow, and that's very obvious because you don't have a left atrial appendage, but the success rate was not 100%, meaning because there was still a significant stump that people left. Now, with the other techniques, which at that point was exclusion, you can say that the persistent flow is still was only, well, the lack of persistent flow was in 61%, and successful closure was in 23%. So we're talking about a significant failure of this device on transesophageal echo many years ago. Now, when they looked if there was a residual clot in this remnant of left atrial appendage, it came up higher according to suture exclusion and stapler exclusion. So what I'm trying to say is that even though you may try to get it excluded, there's still a risk of failure, and the risk of failure means there's still a risk of having a clot and stroke afterwards. This is from the same paper, echocardiogram images. You can see that there's residual communication between the left atrium and the left atrial appendage, and that is confirmed by flow in the second one. And in this less third echocardiographic picture, there's a residual stump bigger than 1 centimeter with the potential of having clots in this remnant. Now, to try to overcome this problem, there's been advancement in technology, and this is the clip. This is a meta-analysis gathering 11 study with almost 1,000 patients, and they describe success rate of close to 100%, which is very good comparing to what we were describing before. There have been no incidents of left atrial appendage flow or leak. There was no device complication according to this analysis, no incidents of bleeding, and no migrations. And as of today, there's more than 500,000 patients already with the clip device placed on. So this is a video. This is Dr. Bapat who shared this video. And first thing you can see that the heart is arrested. There's cardiopulmonary bypass, and that's why the whole heart is decompressed. But it's not necessarily to place a clip for it to be arrested or not. Actually, you can do it through a thoracoscopic approach and the heart beating. This is the clip. The first thing is the analysis to determine if it's which size. There come in different sizes. And what you can do is make sure that you're grabbing the whole left atrial appendage. And if you don't like the position, you can eventually recapture it and make sure you grab it again. And the thing that I'm trying to show, this is a real-time video that is, I mean, I wouldn't say simple, but it's not complicated. Meaning it's around a 1 minute procedure to make sure you have no left atrial appendage. So he's going to release it, and that's it. And we talked during this 1 minute. It's a little more tricky to be able to do in a redo surgery since there's more adhesions, but it can eventually be tried to get it done. This is also pathology on patients with a clip, 90 days in an animal. You can basically see a scar, but you don't see significant left atrial at all, so it looks very nice. And this is a redo patient, human, on the second picture. At 7 years, he had to go for another surgery, and you can barely see the scar where the left atrial appendage was located. Now let's talk about evidence and literature that we have. So this is the first trial with left atrial appendage occlusion study, which is LAOS, and it's a result as a pilot study to occlude it on patients that are going on coronary bypass surgery and see what's the risk of stroke. So they grabbed patients that were going coronary bypass surgery, and 77 were randomized 2-to-1, either suture or stapling. You have to think this is 2005, so at that point, that was the standard of care, how to treat this versus control. And they defined patients that had a higher risk of atrial fibrillation and stroke, and they define it as age more than 75, hypertension, previous stroke, and history of atrial fibrillation. And they did a transesophageal echo at 8 weeks to see if it was successfully treated or not. And they're already talking about this success rate is a stump less than 1 centimeter or flows in into the left atrial appendage. And the anticoagulation was left at discretion of their primary physicians. So the successful closure of left atrial appendage from this randomized trial showed that the success was not really that great, 72% in the stapling device and 45% when you did an epicardial suture alone. But the important thing about this study is that it was safe. You could have it done. There was no significant increase in time of surgery. There was no significant increase of Lasix, and we'll talk about the heart failure relationship with the left atrial appendage later in our talk. And there was no significant bleeding and no significant atrial fibrillation. So meaning that you could do it with basically not increasing risk of surgery. This came to the left atrial appendage occlusion study 2, the LAOS 2, and it's also a pilot trial, and they randomized a small number of patients, 26 to get it occluded and 25 to not get it occluded. And as we know already, the procedure was safe, but they went on to compare 1-year results, and at 1 year, the composite endpoint of death, MI, stroke, non-cerebral emboli, or major bleeding was the same. So at least it did not increase the risk, but again, it was a very small number. Until then, this is from the European Journal 2014. They did a meta-analysis of all the research that was done at that point about surgical left atrial appendage occlusion during cardiac surgery. And what they did is compared between 30 days and the long-term follow-up. And at least at the long-term and at the 30 days, the embolic incidence was favoring left atrial appendage on patients that had the procedure done in this meta-analysis. Now, when we talk about our percutaneous approach, in this case, it's a meta-analysis published in JACC 2017, that they compare the two big trials with the Watchman, which was the PROTECT AF and the PREVAIL study. I think the important thing to notice is that the big benefit and why the Watchman was approved is basically because they decreased the rate of hemorrhagic stroke because of the less need of anticoagulation, but it did not really show a significant benefit in ischemic stroke, and that's how it got approved. And this all comes to this big study, which is kind of our game changer for our approach regards left atrial appendage. This is the left atrial appendage occlusion during cardiac surgery to prevent stroke, or LAOS 3, and this was published in the New England Journal 2021. And what that is, a multi-center randomized for over 4,800 patients with a mean age of 71, and they were all patients that were going cardiac surgery with cardiopulmonary bypass and already had atrial fibrillation with a CHA2DS2-VASc score equal or greater than 2. And their primary outcome was to see if there was ischemic stroke or systemic embolism. And all these patients had guidelines-directed stroke prevention therapy with oral anticoagulation that was left to their local physicians, and they were blind. They did not know if the patient did get an occlusion or not. Now, another important thing about this trial is at this point, 2021, the technique to occlude the left atrial appendage was not standardized. It was left up to each center. Most of them, more than half of them, had the left atrial appendage cut off and sutured back. 11% had the stapler device put, and 50% had the clip done. So I'm trying to say it was not still standard of care which way to treat it. Now, when you talk about results, regards timing of cardiopulmonary bypass and cross-clamp time, it was slightly higher on the patients that had occlusion. We're talking about 6 minutes higher, which in the surgical world, it doesn't really make much of a difference, the 6-time difference, a 6-minute difference. But we do know that regards bleeding, reoperational bleeding, prolongation of hospital stay due to heart failure, and mortality, there was no difference. So again, the procedure was safe, either if you excluded it by cutting off or put a clip or put a suture around it. Now, the main result from this trial is when they talk about the cumulative incidence of stroke and systemic emboli. And as you can see, when time goes by, and this was a 4-year follow-up, the occlusion had less incidence comparing to the non-occlusive arm, and these curves keep spreading apart with time. Now, the number to treat to prevent a stroke was 46 at 4 years, and the prediction said if you go to 5 years, 6 years, it will keep getting lower numbers to treat. Now, the important thing is that the LAOS did not compare left atrial appendage with anticoagulation. It was not part of their intention of the trial. This is the same results, just to look at it a little different. We said it was 2,400 each arm, and the incidence of stroke was 7% in the non-treated arm versus 4.8, and that's a reduction of about 33%, and around 75% in each group, which is not different, were on anticoagulation by the end of the trial. From this same trial, there was a sub-analysis. This was published in Circulation in 2023, so it's the same LAOS 3 data. And the important thing with the anticoagulation is that it remained mostly stable through time in the same 75%, and was not significantly different between both groups. But there is a difference regarding which kind of anticoagulation. As you see in the blue bar, there's decrease of use of Coumadin with the increased use of DOACs with the follow-up. Now, again, the intention of the trial originally was not to compare anticoagulation, but we know the surgical left atrial appendage provide protection against ischemic stroke, despite the fact that some patients were not taking anticoagulation. So it makes the argument if really anticoagulation is needed in patients with left atrial appendage occlusion. Another study also of this sub-analysis from the LAOS trial, this was published in the Journal of American Heart Association, and they analyzed cost. So what they did is they went to the data Medicare reimbursement, and they see if it was cost and benefit if you clipped or not, or excluded or not the left atrial appendage. And as a result, overall, the number of patients, the cost of patients that were occluded were less expensive, they were cheaper. And that was mainly due to the chance because they had less strokes. Now, this is true in all groups, but except when you had a device placed in, because the device has a cost itself. It's a $600 reduce. Now, when we go to guidelines recommendation, these are the two guidelines, 2019, the American Heart and ACC, the first column, and table 2 is the 2020 European guidelines for atrial fibrillation. And when you go to these guidelines on the American one in 2019, surgical occlusion of the left atrial appendage is recommended to continue anticoagulation because of the risk of atrial fibrillation and stroke prevention. That's a class recommendation 1. And that's true because so far no study has really compared left atrial surgical exclusion without anticoagulation. And also in this recommendation and this guidelines, it's a 2B to do the left atrial appendage occlusion during a surgical intervention in patients undergoing with atrial fibrillation undergoing surgery. When you go to European guidelines, at the same time, it's around 2B to recommend it to have excluded at that point. Now, with all this new evidence from the LAOS 3 trial, the STS, our society, in 2023 updated their guidelines for atrial fibrillation. This was published at the beginning of 2024. And this guidelines, when you compare between 2017, which was the previous STS, with the 2023 one, there has been an increase of recommendation and level of evidence from a 2A to a 1A. 1A, left atrial appendage obliteration of atrial fibrillation is recommended for all first-time non-emergent cardiac surgical procedures with or without concomitant surgical ablation to reduce morbidity for thromboembolic complications. So again, the LAOS 3 trial was such an evident game changer that it changed our guidelines. And also, as a 2023 guidelines, they start talking about as 2B recommendations to have your left atrial appendage removed as an isolated procedure, basically no cardiac surgery, no bypass, no other thing related, in patients that have atrial fibrillation and have a contraindication for oral anticoagulation, trying to simulate what the percutaneous approaches do. Now it's still 2B. Now there's also has been an update in the guidelines from the American Heart and ACC Society. This is the 2023 one. And with the LAOS 3 trial, they always also made a difference. Remember before it was 2B, now they changed to a 2A recommendations. They're a little more specific though, meaning that atrial fibrillation patients that are going cardiac surgery should have a CHA2DS2-VASc score of 2 to justify. But another important thing that they mention is that with a 1A level, that we have to make sure that there's no residual stump and there's no residual flow to this cavity. This is a nice summary of what we're talking. I just want you guys to focus on the blue line. This is the surgical left atrial exclusion. As you go with time, with the different trials, there's been an increase of level of recommendation and level of evidence that at this point is 1A for the ACC, American Heart Association, and STS to do this kind of procedure. Now, interesting, adding to all this, this is published in our last STS meeting, which was done at the end of January. And this is our registry from the STS. And despite all this new evidence, in 2022, you can see on the green line, there has been increase in numbers of patients that just go to left atrial appendage. These are all patients that have atrial fibrillation. There's a slight increase on patients that go to with a MACE procedure and a left atrial appendage. But I think the more important thing is the purple line, that despite all this new evidence, there's still around 30% patients that go to cardiac surgery on atrial fibrillation and don't have anything done. A different subject, which I think is important to talk about, what happens electrical to this left atrial appendage. So this is a patient that underwent a clip, and they did an epicardial mapping as a hybrid procedure to see how was the electrical, if there was any electrical conductivity after the clip was placed. And you can see in the images that also the clip is not only isolating or excluding blood, but it's also isolating electrical, the left atrial appendage. And that's important to consider because some patients with atrial fibrillation, 25 to 30% of patients, the ectopi or the foci of the atrial fibrillation comes from the left atrial appendage. So it could be helpful in that end too. Now, hemodynamically, the left atrial appendage, its role, we know it's a reservoir for blood, so it helps with the cardiac output. It also produces atrial and brain natriuretic peptide, but it's an unknown effect. What happens once you take it out? There's some arguments that you may need some more diuretics, a longer hospitalization for heart failure, but that has never really been fully proven. Now, regards to the future, where all this is going, I think there's two big answers to questions to be answered. And what should every patient undergoing cardiac surgery be considered for a left atrial appendage? And you're probably going to hear a lot about it and a lot of push, especially for surgical teams, saying it's a straightforward, simple procedure. And I think the important thing is to find who has a risk of atrial fibrillation or stroke. And we know that our population of cardiac surgery, around 50% of the patients have this high risk for atrial fibrillation and stroke. And that's what we call an atrial cardiomyopathy. And that is based on patients that have hypertension, advanced age, heart failure, valve disease, or left atrial enlargement. And in this group of patients, someone could justify to have their clip excluded at the time of surgery. And you also have to think, because this is a one-time chance that he's going to go to the OR with a simple procedure, and we're talking about a third reduction of stroke according to the latest 3 trial. And to try to answer this question, the LEAPS trial is undergoing. Actually, we have some of our patients have been enrolled in this trial, and the LEAPS stands for left atrial appendage exclusion for prophylactic stroke prevention. So the plan of the trial, and it's an enrollment part. From what I understand, the enrollment should be done. It's 6,500 patients that are going to be randomized either to a clip or no left atrial appendage exclusion. And these are all patients that are not on atrial fibrillation, but do have those risk factors, which we talk about: advanced age, at CHA2DS2-VASc score, even though they do not have atrial fibrillation, but it's equivalent to consider high risk, or they have an elevated pro-BNP. And they're going to be followed at 1, 6 months, 12 months, and up to 5 years to determine the reduction in their risk of stroke risk. And this is a summarize of that. So when the atrial fibrillation, because of the CHA2DS2-VASc score, it's about 30% of our patients. With this new trial, we're trying to focus on the 60% range of our patients, and there should only be less than 15% of patients that are low risk for atrial fibrillation, that at this point should probably have nothing done. Now, the second question to answer is, can patients with atrial fibrillation and had a clip done, can we discontinue anticoagulation? And this is to make the similar therapeutic approach as people that have a Watchman or another percutaneous device. And this is a trial that is going to start enrolling now in 2024. It's in Denmark, and what they're going to do is grab a group of patients that already have a left atrial appendage occluded, a clip placed, and they're going to do a cardiac CT to make sure that the clip is working. And they're going to randomize 1,200 patients either to have discontinuation of anticoagulation or just keep them with and see if there's any significant change on them. So finally, to conclude, atrial fibrillation and left atrial appendage clot is an important risk factor for stroke. Left atrial appendage occlusion is safe and effective treatment in decreasing the risk of stroke. And I'll probably go it's safe and effective either when you clip it or you cut it and sew over it. And I think there's a very important for all us surgeons that there's a need to increase surgical left atrial appendage, hopefully in all our atrial fibrillation patients. And I think these are the two questions that still need to be answered is can it be indicated in all patients that are on sinus rhythm but at a high risk of atrial fibrillation? And if anticoagulating will be needed at the long term of patients that have left atrial appendage occlusion. Thank you.
Good morning. My name is Atsushi Okada. So continuing on to this talk, I would like to talk about the AtriCure study, which is a study that we are conducting at MHIF. So continuing on to this study, there are several devices that are in the market for use to isolate the left atrial appendage. On your left is two examples of transcatheter devices. One is called Watchman, another one is called Amulet. And the purpose of both of these devices is to approach the left atrial appendage from the inside of the heart, which means from the left atrium, and plug the left atrial space to isolate the blood flow from going in and out and to prevent the blood clot from forming inside. And on the right side, today's talk is about surgical devices. And one of this example is the AtriClip device. As you can see on this picture, we apply these clips surgically and clip the base of the left atrial appendage at the base of the appendage. And this device is now available in 4 sizes, 35, starting from 35 and up to 50, and between in 5 millimeter intervals. Now, the background of this study is about device sizing. So in transcatheter devices, we do device sizing by pre-procedural imaging, including transesophageal echo or by CT. On the other hand, when we think of the surgical devices, currently how it's sized is device sizing is during surgery, or in other words, it's on-table sizing using a sizer. And this is a manufacturer-dedicated sizer you see on the screen. Basically, this is a ruler that has the measure at both ends, and a surgeon will take this into the surgical field and measure the size of the left atrial appendage to choose the appropriate size. So the background here is that how we could apply imaging in surgery is unknown. So in other words, the usefulness of pre-procedural imaging, particularly CT, for atrial sizing is unknown. And I think it's really easy to understand that appropriate device sizing is crucial. So you see on the figure, we measure the atrial appendage and decide the size and place the clip. However, for example, if you image, if the clip is too small, it can result in incomplete closure. And if it's large, the clip may interfere with surrounding structures such as coronary arteries or pulmonary veins. Since the heart is packed in the endocardium and there's not much residual space around, so we need to avoid placing large clips which could interfere with these findings. So the aim of the study, we sought to investigate the association between the theoretical CT predicted size of the clip with the implanted size during surgery, and their association with imaging outcomes, which means what's the findings on a prospectively conducted post-AtriClip CTs, both in patients undergoing AtriClip placement. So we prospectively enrolled patients undergoing open heart surgery at Abbott Northwestern and clinically indicated for left atrial appendage ligation using the AtriClip device. So 24 patients completed the 30-day follow-up CT, and I would like to present the results of these patients. And these are the four major things that we evaluated: the baseline characteristics of the patients, the pre-AtriClip CT, and then AtriClip sizing during surgery, and then the post-AtriClip CT performed at 90 days after surgery. So we're going to go into the imaging field. So this is what it looks like on a pre-AtriClip CT. So the left ventricle, left atrium is here, and left atrial appendage is a blunt structure that is from the left atrium. So you see the left atrial appendage here. And then important structure here is the left circumflex artery, which is one of the branch of the coronary arteries, which is right below or right at the base of the left atrial appendage. So importantly, this green line is called the left appendage ostium, which is at the base of the left atrial appendage. And this ostium is pretty standardized in device sizing for transcatheter devices. And the area and perimeter here shown in the short axis view is one measurement that is considered in deciding the transcatheter device size. And for this study, we also measured which we just named clip plane, which is parallel to the ostium but above or distal to the circumflex artery. So theoretically, the AtriClip is placed at this level, avoiding interference with the circumflex artery. And we also looked at the area and perimeter of this level for device sizing. So here's how we predicted theoretically the AtriClip size. So you see that left atrium in short axis is an oval shape. And when a clip is placed, it will be made flat. So theoretically, the perimeter divided by 2 should be the clip length. So that will generate this table saying that if your perimeter at the clip plane, for example, between 70 and 80, the perimeter divided by 2 would be the size for a AtriClip 40, and so on. But importantly, we only have 35 between 50 size AtriClip. So if the perimeter was 70 or smaller, it would be a 35, independent of the size. And if it's larger than 90, it would be the 50, which is the largest size available. Another important finding, we carefully evaluated, which is called a trabeculation or a lobe near the clip plane. So if you look at the left upper panel, you see the appendage here, and this would be the ostium or the base. And you see this rough structure really close to the level where the clip would be placed. And I think you can easily guess that if you place a clip and if the place was not exactly at the base, you could leave this trabeculation or a lobe, which could lead to some concerns for blood clot to form. An AtriClip sizing was done as previously explained, and we compared this with the CT predicted size, whether it was the implanted clip was smaller than the CT predicted, or it was same, or which was larger, and what kind of influence this has. And here's an interesting slide. So on post-AtriClip CT, we see a CT image like this. So you have the left ventricle and left atrium here, and this white, bright structure is the AtriClip. And previously you saw the appendage sticking out from here, which is now completely exceeded by the AtriClip. So the first important outcome would be complete exclusion, which means no contrast was going to the other side of the AtriClip. And then the second was there any thrombus formation at the atrial side of the clip? And also, there has been a term called stump used in this field. So on your left hand, you see, I think everybody would agree that we do not see any residual or a stump where the left atrial appendage was. However, in reality, we do see some cases where there is a small stump left or even a larger stump left when we evaluate the imaging post-procedure. The previous literatures have suggested that 10 millimeter might be a reasonable cutoff to stratify the risk. And for this study, we analyzed the cutoff to be 10 millimeters. The next interesting point, even if the stump is less than 10 millimeters, we do see some cases, like on this figure, even if the clip is appropriately placed, we do see some trabeculation or a rough zone near the clip, which do raise a slight concern in thrombus formation. And the same would be true even if there's a large stump. And last but not least, an important outcome is the clip interfering with the surrounding structures. The coronary artery is next to the clip. So this image is demonstrating that the atrial clip was proximity to the left main trunk of the coronary arteries, or the atrial clip could be interfering with the left superior pulmonary vein, which is next to the left atrial appendage. So here are the baseline characteristics. The most used atrial clip size was 40 in 38%, followed by 35, which was in 25%. 46% of patients had an aortic valve surgery, followed by 42 patients receiving a mitral valve surgery. There's an interesting term in the field of cardiac imaging. These are the shapes of the left atrial appendage. I'm sure some of you have heard of this. There's a term called chicken wing, cactus, windsock, cauliflower. So 9 patients were chicken wing and 9% were windsock. And as explained, the ostium and the clip plane area and perimeter was measured. And here's a very interesting finding. The trabeculation or a lobe near the clip plane was found in 50% of the patients. And when we look at the post-atrial clip CTs, so a stump which was larger than 10 millimeter was found in 25% of the cases. And the residual trabeculation in the stump, which means there was a stump and there was a rough zone inside the stump, this finding was observed in 50% of the cases. And interestingly, this is not affected by the depth of the stump, which means even if you have a very minor stump left, you could have a residual trabeculation in 50% of the case. And here's showing the clip interference with the surrounding anatomy. The proximity with the left main was found in 1, and proximity with the superior pulmonary vein was found in 4 cases. However, all of these imaging findings were subclinical, which means the patient did not have any clinical significant problems. I'd like to show a few slides what we are seeing. So this figure is plotting the implanted atrial clip size compared to the perimeter on the pre-atrial clip CT. So theoretically, the device size should land in the green zone. However, as you see, there are some cases which is widely away from this zone. And these are some cases which the clip was placed with a large stump, residual stump. So for example, you can see if you have a really large size atrium, there is more high chance that you could leave a stump. And we are seeing some interesting signs. So if the clip that was placed was larger than CT predicted, you could have higher chance of leaving a residual stump. Or if your clip is large larger than CT, there is higher chance for the proximity with the left superior pulmonary vein. Another aspect, how could we predict the outcomes from the pre-CT? So for example, on the CT, if your perimeter is larger than 100 millimeters, there is higher chance for a residual stump. Or if you have a trabeculation or a lobe near the clip plane on pre-CT, there is higher chance for a residual trabeculation, which could be predicted. So these are some interesting signs we are seeing. So to conclude, Atrial study is a prospective evaluation of pre and post CTs in patients undergoing LAA elimination using the AtriClip device. And both pre and post CTs can provide important information which could contribute to better outcomes for our patients. Thank you for your attention.
Awesome. Nice job, both of you guys. Any questions?
Thanks for both of you for the talk. That was great. So I guess a question to each of you. The first thing is how often do you incidentally find a clot in the left atrial appendage in our, the thousands of patients that undergo CT, CTA imaging?
Mm-hmm.
And then the other question, maybe more for Sebastian, is when you externally ligate the appendage, do you crush the blood supply so it just becomes necrotic, or is that tissue still viable even though it's excluded?
Yeah, so I would like to ask. So I think there is no percent data on that, and it really depends on the patient situation and how you evaluate the blood clot. Because obviously, if you have atrial fibrillation and other risk factors, there would be higher risk for a blood clot formation. And then there is another difference between how you evaluate, if is it by CT or is it by transesophageal echo or is it by transthoracic echo, and there's a different percentage that you could catch the blood clot. To your question, I think there's no prospective data that could answer that question.
So regards surgery itself, we all do our cases with transesophageal echocardiogram, and we take a look at the analysis before surgery, see if there's not a clot. If there's a clot in the left atrial appendage, I would personally not put a clip in there. I would open it up, take out the clot, and close it afterwards. I guess there's always a risk that with the clip you might potentially migrate towards the left atrial line. If you don't see it, you potentially embolize that clot. Now, regards, sometimes there's people that open intentionally the left atrial the tip to decompress it. And sometimes with the same forceps, you can cause a hole so it starts bleeding. And once you put the clip, you see that the whole left atrial appendage gets excluded of blood right away. So there's a mechanical compression that prevents all the blood going from the left atrium to the left atrial appendage. Afterwards, it will be a scar. If you go back, for any reason you see it, there's basically a small little tissue scar from the outside. And then you saw the pictures in the pathology. In the inside, you can barely notice where the hole was.
Thanks again to both of you. Dr. Iturra, you showed the New England Journal of Medicine cumulative incidence of with and without the clip or the exclusion. The curves were diverging as time went along with benefit for the clip. Is there any knowledge about why that might be, that continued divergence in risk after surgery?
So first thing too, I just want to clarify, with the latest 3 trial in New England, a small group of patients went to the clip. So it's just occlusion or exclusion. It's not necessarily the clip. And the risk keeps diverging because the longer or the older we get, the more chance of stroke. And most of the not most, but 25% of the strokes come from left atrial appendage clots. So the longer time follow-up, it's supposedly more chance of benefit of this exclusion device. And I mentioned that the N number to treat at the 4-year follow-up was around 40. If you keep perspective that number, it should be 30 by around 5 to 6 years, and it will keep diverging with time. So the new LEAPS trial, which is kind of the same concept with a more healthy population. That's why they have to go with such a big number of patients to try to see that benefit. Otherwise, you will never find the potential, if it has a beneficial effect in clinical amount.
Yeah, so we have, first of all, thank you so much for your talks today. We have two virtual questions. The first comes from Dr. Lesser. First, he states, wonderful talks. And the question is there a role for surgical exclusion of the LAA in patients with very large or very small LAA ostia?
So is there a question for me or is that?
It does not specify.
Oh, okay, sure. So the question was, is there a role for surgical exclusion in very large or very small atrial appendage? Is that correct?
Yes.
Yeah. So if we think about the atrial clip, which is the main topic today, we have 4 sizes now. And obviously, if the appendage is too large for the clip size available, I think it's reasonable to consider another way of LAA exclusion. However, another question would be, should we have a larger size or a smaller size available? And that would be the next question for our research.
Just to add, one of the, it's not here and it's really hard to actually prove it, but the patients that had communication when you suture it and there was a filtration back and there was a clot, they were potentially in even higher risk of stroke because there was more chance of having clot in the left atrial appendage. So even though there's a small orifice, there's still a chance of having clots in the left atrial appendage and eventually embolize into the brain and the rest of the body.
Great, thank you for that. The next question comes from Dr. Bapat. It does not specify who this is for, so if you both would like to comment on it. But the question is, if we have ligated the appendage and the patient is in NSR, can we do a CT and then not anticoagulate them if they go into post-op AF? Let me know if you need me to repeat that.
Yeah, so we don't know, and that's the truth. This is from personal experience. If we put a clip and we have a patient atrial fibrillation, and for any reason there's a risk of bleeding or you have hemorrhage in the post-op, I feel a little more safe with not continuing anticoagulation if there was a clip placed versus a patient that does not have a clip. But the truth is, all the evidence does not show us if it's safe or not. And that's why there has to be new trials to answer that. I know that's the difference from the percutaneous world, that there is evidence to discontinue anticoagulation when you place either the watchman or the amulet. But for surgery, as of now, if a patient has a clip, should still be anticoagulated afterwards. More questions?
Thank you so much.